Good morning, everybody, and welcome to my grand rounds. Thank you all for coming. For those of you who don't know me, my name's Megan, and I'm one of the third-year FR residents. Over the next 50 minutes, I'd like to delve into the world of migraine headaches and hopefully share some ideas with you that you can take with you on your next shift. My goal for today is to improve the care of our migraine patients both in and out of the ED. In part one, we'll explore just how disabling migraines are and why it's crucial to provide optimal therapy, and then we'll evaluate our current treatment practices. In part two, I'll equip you with an evidence-based approach to migraine management beyond the common ED cocktail, specifically appraising the role of IV valproic acid, Spenopalatine ganglion blocks, and determining whether there's a role for ketamine or opioids in migraine management. In part three, I plan on expanding your scope of practice to better treat migraine patients by getting you comfortable with abortive and preventative therapy. And lastly, in part four, I'll introduce the upcoming CGRP antagonists and dietins for acute migraine treatment. As some of you may know, Dr. Tamara McCall also did her grand rounds on novel migraine therapies back in 2015 and did an awesome job covering propofol, magnesium, and dexamethasone, so I won't be addressing these today. If you'd like more info on these, please refer to her video on the EM Ottawa YouTube page. Also, due to time constraints, I won't be covering the role of occipital nerve blocks in migraines today. Okay, let's start with part one by jumping in with some quick facts. Migraines affect 1 out of every 5 people, with women being 3 times more likely than men to suffer from migraines, and they're more commonly seen in those in their 20s to 50s. With this age distribution, migraine prevalence tends to peak during people's period of highest productivity. According to a study by Zhang in 2016, migraine ranked as the 3rd highest for productivity loss secondary to missed workdays after mood disorders and back problems. And alarmingly, according to the 2004 WHO update on global burden of disease, a severe migraine attack was ranked in the highest disability class, labeled as being as disabling as being quadriplegic, having active psychosis, or even having terminal stage cancer. So it goes without saying that migraines are not simply a benign disease, and instead they have far-reaching consequences with significant impact on quality of life, ability to function, and are an issue with significant economic and societal burden. Okay, let's start with the case. You're seeing Anna, a 28-year-old female presenting with typical migraine symptoms for the past 6 hours. She has a prior history of migraines, which have worsened lately, which she attributes to her increased stress ever since finding out her sister is an ice princess. She's otherwise healthy and only takes acetaminophen or ibuprofen as needed for headaches. I'd like you to keep Anna's case in your mind as we go through the talk today, and we'll come back to help her out along the way. I would bet that Anna's case probably sounds pretty familiar to you since we get so many visits to the ED for migraines. And I think it's fair to say that once we've diagnosed our patient with a migraine, most of us will treat their pain with our migraine cocktail, then send them on their way once their pain has improved. But I'll ask you to consider whether our job is truly done at that point. For now, I'll say that it's important to note that there are several different types of migraine syndromes, and while differentiating between them won't necessarily change your initial management, it will become important when getting ready to discharge our patients, and we'll come back to this point later. But for now, let's focus on what we can do for Anna to relieve her immediate symptoms. We have a number of different options at our disposal when treating an acute migraine in our ED, including IV fluids, ketorolac, dopamine antagonists, and triptans or ergosts, among others. So let's see what the guidelines suggest. As per the Canadian Headache Society, there are 3 acute therapies that should be offered as first line to any and all patients presenting with an acute migraine attack: ketorolac, dopamine antagonists, and triptans. They all come with a strong recommendation with high quality evidence to back them up. With respect to ketorolac, don't forget that there are studies suggesting a dosage ceiling effect, with pain relief being the same whether you choose to treat with 10, 15, 30, or even 60 milligrams, with lower rates of complications at lower doses. So it's not unreasonable to use a lower dose when treating migraines in the ED. With respect to dopamine antagonists, research suggests that metoclopramide and prochlorperazine should be your first-line antidopaminergic agents, with chlorpromazine and haloperidol being other available but less effective options. And lastly, the CHS recommends the use of sumatriptan in those without contraindications, as they have been shown to be very effective in acute migraine management, while ergotamines have not come as strongly recommended, secondary to an unclear risk-benefit profile and weaker evidence to support their use. Okay, so back to Anna. You give her the classic cocktail as listed here, but upon reassessment, she states that her headache pain is still severe. So you decide to give her 1 gram of mag sulf and start wondering what other therapy options you could offer her. This brings us to the next part of our talk, where we'll focus on acute migraine adjuncts, some to adopt and some to avoid. Specifically, we'll go beyond our classic cocktail and talk about IV valproic acid, Spenopalatine ganglion blocks, and ketamine. We'll start with valproic acid. Since it's an accepted option for migraine prevention, it's triggered some research looking into whether the IV formulation can be used as an abortive therapy as well. Although the pathophysiology is not well understood, it's believed to have an effect through its ability to increase GABA levels in the central tracts associated with headache pain. Let's look at what our docs are doing here at TOH. And thank you to everyone who filled out the survey. I got a total of 100 responses, which is super awesome. So based on the survey results, it's clear that the majority of us are not using IV antiepileptics when treating acute migraines, with 92% reporting never using it or rarely using it. So what's all the fuss about? Well, although there are many benefits, the 3 most appealing reasons to use antiepileptics, such as valproic acid, stems from their lack of cardiovascular effects, making them suitable for those with contraindications to triptans or ergots, their lack of sedating properties, and their lack of potential for addiction or medication overuse, as seen with drugs such as opioids. So this all sounds great, right? But what does the research say? Several studies have been done comparing various doses of VPA, ranging from 400 milligrams to 1 gram IV, compared to standard therapy. And overall, the results are mixed. We'll go through a bird's eye summary of the highlights from the 4 main trials done to date, and then we'll critically appraise the strongest one, seen here at the bottom in orange by Bakshayesh. Up top in blue, you can see the study by Edwards, which showed that VPA was considered equally effective as the combination of metoclopramide and DHE at improving headache pain within the first 4 hours after initiation of treatment. Whereas in the study by Tannen, VPA was found to be significantly less effective at reducing pain and nausea scores when compared to prochlorperazine. And here in purple, you can see that the Friedman study found it to be as effective as ketorolac, but less effective than metoclopramide. These findings make it really difficult to know how to apply this to your practice. So let's look at the 4th study here in orange by Bakshayesh a little more closely. Maybe it can help us clarify some things. This study was published in AGEM and was an open-label RCT, which was based on 60 patients from a single center ED in Iran. They included any adult patient who presented to the ED with a prolonged migraine without aura. They compared 400 milligrams of IV VPA to the combination of metoclopramide and sumatriptan. Their primary outcome looked at the efficacy of these medications in their ability to relieve headache pain at various time intervals up to 24 hours, with relief from associated migraine symptoms as a secondary outcome. Relief of headache pain was defined as a reduction in pain from moderate to severe on the visual analog scale to none to mild, which was assessed at 20 minutes, 1 hour, 2, 4, and 24 hours after administration. They also assessed relief from associated migraine symptoms, including nausea, vomiting, photophobia, and phonophobia, and rated these on a scale of 1 to 4 from mild to severe over the same time course. What they found was that treatment with VPA was associated with a more rapid onset of action, better efficiency, and a faster trend of pain reduction than the sumatriptan metoclopramide group, which is demonstrated in this graph. Here we can see the mean pain reduction scores between the 2 groups on the y-axis over time, which is on the x-axis. As you can see, for the first 2 hours, there's a notable difference between the VPA group in blue and the sumatriptan metoclopramide group in red with respect to the degree of pain score reduction. However, after the 4-hour mark, the differences are less pronounced and are not statistically significant. However, with respect to alleviation of migraine-associated symptoms, there were no significant differences between the two arms. So overall, the authors concluded that IV valproic acid was significantly more effective at reducing pain in the first 2 hours of treatment in patients with prolonged migraine, which is a promising finding. However, it did not show any added benefit to associated migraine symptoms over standard therapy. Some strengths of this study include that they compared the drug of interest to metoclopramide and sumatriptan, both of which are drugs that are known to be effective in treating migraines. Secondly, they focused their outcomes on patient-centered symptoms, such as a reduction in pain to mild or none, as well as on relief from associated migraine symptoms, which are markers that we use when determining when a patient is ready for discharge. They also studied an ED-based population, making it applicable to our practice. Despite this, some limitations include that this study was done at a single center in Iran, their use of an open-label, non-blinded design opens the results to bias, and they had a small sample size of only 60 patients. In all these studies, side effects from a single dose of VPA were uncommon, but included nausea, dizziness, and flushing. There were no serious adverse events noted in any of these studies. So in summary, currently, the evidence for VPA is mixed, and the optimal dose is uncertain. Most of the studies performed to date are small and are of limited quality. However, there is growing evidence that VPA may have a role, and I would say that it provides another option to consider should a patient fail or have contraindications to our standard therapy. In speaking with our neurology colleagues, they strongly support its use and state that although most of the evidence is open label, many experienced neurologists swear by it. They suggest a good rule of thumb is using a 15 milligram per kilogram dose or 900 milligrams IV at a rate of 20 milligrams per minute. It'll be important to ensure the patient is not pregnant and that there's no history of hepatic disease. That being said, unfortunately, currently it's available by special access only. So for the time being, neurology will have to be consulted before it can be used, at least until we get our own SAP supply for migraines approved in the ED. Next, let's dive into Spenopalatine ganglion blocks for acute migraine treatment. The Spenopalatine ganglion is located behind the middle nasal turbinate and is implicated in headache syndromes. It sparked interest as a target for a local block in the treatment of migraine headaches. In my survey, I asked how often our docs here at TOH use SPG blocks in the acute treatment of migraines, and was actually pretty surprised to see that many of you are already using it quite often, with just under half of you reporting using it sometimes, usually, or even always. Let's see if the research backs us up. There are a number of different ways to perform an SPG block, from instilling liquid lidocaine directly into the nose, to using a nasal spray, to using a targeted device to access the SPG. We're going to look at the evidence behind the two methods shown here. Let's start with the installation of liquid lidocaine into the nares, best summarized by a review article done by Mojica in 2017. Essentially, their review looked at the efficacy of SPG blocks in migraine headaches, cluster headaches, and other trigeminal autonomic cephalalgias, but I'd like to focus on 3 of the studies that they included in their review, which looked specifically at migraines. All 3 looked at the use of 4% lidocaine applied intranasally using what's known as the method of Barré. Essentially, this method consists of having the patient lie with their head extended over the edge of the bed by 45 degrees and rotated 30 degrees towards the affected side, while half a ml of lidocaine is dripped into the nares over 30 seconds, effectively targeting the SPG. So the first of these studies is the Kudrow study, which was done in 1995, and was the first of its kind to investigate the use of lidocaine in this way for the acute treatment of migraine headaches. They found a significant reduction in migraine pain severity after the administration of lidocaine. This study was quickly followed by Maisels in 1996, who conducted the first RCT done to investigate this topic. They compared IN lidocaine to IN saline and found the lidocaine group to be significantly more likely to have achieved a 50% reduction in their headache pain as early as 2 minutes post-treatment, as well as a significant reduction in their associated symptoms and their need for rescue medication. The third study was spearheaded by Maisels again and was another RCT comparing lidocaine to saline. They found lidocaine to be superior in terms of clinically significant pain reduction at 15 minutes. So overall, Mojica's review study concluded that an SPG block is a safe and effective option for the treatment of various headaches, including migraines. These 3 studies were limited by small sample sizes, the potential for unblinding, given the taste and associated numbness sensation associated with lidocaine, as well as the fact that the application is technique dependent, which could affect the outcomes seen. Now let's quickly look at a more targeted approach to the SPG block, which was investigated in a study by Schaefer in 2015. They performed an RCT with 93 patients from 2 academic EDs, testing the efficacy of an SPG block for the treatment of acute anterior headache using what's known as a TX360 device. They compared 0.5% bupivacaine to normal saline. Their primary outcome was a 50% reduction in pain at 15 minutes, while their secondary outcome included the percentage of patients who were pain-free at 24-hour follow-up. Here's a picture of the TX360 device that they used in this study, which essentially is a long, soft tube inserted through the nose that targets the SPG. With respect to their primary outcome, a 50% pain reduction was achieved in just under half of those in the bupivacaine group and in 41% of those in the saline group. And so they failed to find a significant difference between the bupivacaine and saline groups with respect to this primary outcome. However, with respect to their secondary outcome, 72% of the bupivacaine group achieved pain freedom at 24 hours, compared to only 47% in the saline group. So they did find a significant difference with respect to the percentage of patients who were pain-free at 24 hours. Of note, however, despite this great NNT of 4, they did report a large confidence interval, and consequently, more studies would be needed to confirm where the true point estimate lies. So overall, their conclusion was that for patients with acute anterior headache, an SPG block with a targeted TX360 device was not more effective than placebo in achieving significant acute pain relief. However, it was more likely to achieve pain freedom at 24 hours. One of the most important limitations of this study was the 15-minute cutoff they chose for their endpoint. As we know, bupivacaine is slower to absorb and has a later peak effect than lidocaine, and so it's possible that the 15-minute cutoff was just not long enough to identify a true effect. Additionally, they included a small sample size, again, the potential for unblinding, and it wasn't designed to look specifically at migraines and instead included any anterior headache. Lastly, it made use of a specific tool which we don't have access to in the ED. That being said, as I'll show you in the following video from ALIM, you can adapt a similar technique using a long cotton swab and the local anesthetic of your choice.
So the block was really quick. It wasn't painful. It just felt like a foreign body sensation in my nose, and the back of my throat felt a little numb.
So as you can see from this video, an SPG block is a low resource, quick and simple procedure to perform that overall appears to be pretty well tolerated. So to summarize, when it comes to SPG blocks, the evidence is mixed, but this is in part because there are different block methods available, and most of the studies done to date have been small and had low quality evidence. Despite this, both methods discussed today seem to have their benefits, and so overall, I would say that SPG blocks are a low-risk option for any patient presenting with a migraine. This sentiment is also shared by one of our very own EM grads and pain specialist, Dr. Dan James, who states that he's had great success using SPG blocks. He uses a 3 ml syringe and fills it with 2% lidocaine, and with the patient in supine position, with neck extended and rotated to the affected side, he instills all 3 ml of lidocaine into the ipsilateral nair over 30 seconds. While he acknowledges that there are different methods available, he states he prefers this method to the cotton swab method for several reasons, including the fact that it's the least invasive, it has the smallest chance of iatrogenic trauma, and it's faster, as you don't need to leave the patient sitting with a swab in their nose for 15 minutes. Oh, and don't forget to bill for this procedure. Its code is G921 for a whopping $12.50. So overall, don't be afraid to give this a try next time you're treating a patient with a migraine. Now let's talk about ketamine and whether it should be considered an adjunct in the acute treatment of migraine. As we know, subdissociative doses of ketamine have been used in a variety of pain conditions, and as such, its effectiveness in headache disorders such as migraines is an area of interest. But let's see what the evidence has to say. Etchison and colleagues did an RCT in 2018 evaluating low-dose ketamine in the treatment of migraines. They randomized 34 patients with acute migraine at a single academic ED to receive 0.2 milligrams per kilo of IV ketamine or an equivalent volume of normal saline administered over 1 minute. Their primary outcome was the between-group difference in pain score reduction at 30 minutes from baseline using an 11-point numerical rating scale as shown here. However, in their study, they did not find a significant difference in pain scores after 30 minutes between the ketamine and placebo groups. So they concluded that 0.2 milligrams per kilo of IV ketamine was not effective in treating acute migraine pain. This study was limited by a small sample size, as well as their use of convenient sampling through a single center ED. Also, while we know from prior literature that analgesic dosing for IV ketamine ranges between 0.1 to 0.3 milligrams per kilo, it's possible that the dose of 0.2 milligrams per kilo used in this study was just not enough. In another study done last year by Benish and colleagues called the THINK trial, which stands for Treatment of Headache with Intranasal Ketamine, they enrolled 53 patients presenting to the ED with any primary headache disorder and conducted a controlled superiority trial. They compared intranasal ketamine to the combination of metoclopramide and Benadryl with the additional option of a dose of ketorolac or dexamethasone. Their primary outcome was a change in pain on the visual analog scale measured at study start and 30 minutes after medication administration. And what they found was that at 30 minutes after drug administration, the mean pain score in the ketamine arm was not significantly different from that in the control arm receiving standard ED therapy. So the main conclusion that can be drawn from these results is that intranasal ketamine is not superior to common IV ED therapies for headache pain. This study was limited by the fact that the population included any type of primary headache disorder, limiting our ability to extrapolate these findings to our patients with migraines. Other limitations included a small sample size and imperfect blinding, given that intranasal ketamine has a bitter taste and smell. Also, the fact that they conducted this study as a controlled superiority trial only allows us to determine that ketamine was not superior to standard therapy. However, we can't draw conclusions as to its effectiveness otherwise or when compared to placebo. That being said, when taken together with the other trial, I would say that overall the research is very limited, and currently the best available evidence does not demonstrate a benefit of ketamine in the acute treatment of migraine pain in the ED. More robust trials are needed before we add this one to our toolkit. So for overall take-home points for this part of our talk today, remember that VPA is an option to be aware of for acute migraine management, but this should probably be reserved for those who fail or who have contraindications to first-line therapies, and for the time being, will need neurology involvement before it can be accessed for this indication. There are different methods available for doing an SPG block, and although the evidence is mixed, it's a low-risk option that I think is worthwhile offering to your patient even as part of their initial treatment. And ketamine, while useful for other pain conditions, is just not ready for prime time when it comes to migraines. Now I'd like to say a few words on opioids in migraine treatment and why we should think twice before considering this as an option when treating our patients in the ED. If we look at our group's practices here at TOH, there's a significant proportion of us using them for migraines, with 1 out of 9 of us giving it sometimes. And research has shown this to be the case in many EDs across North America. So let's quickly go over why this practice should be avoided. The evidence out there is strong in its suggestion to avoid opioids in the treatment of migraines. The research shows that when used for migraines, opioids are not effective. In fact, no RCTs to date have shown pain-free results with opioids, and they've actually been referred to as inducers of headaches. Their use results in longer ED stays. They're known to interfere with triptan effectiveness. They have the potential for addiction and increase the likelihood for return visits to the ED. And very importantly, they increase the likelihood of developing medication overuse headaches, as well as the progression of episodic into chronic migraines. So all in all, opioids should not be your first, second, or third go-to. They are a bad option for the treatment of migraines, and I would urge you to avoid them in your practice wherever possible. To quote Dr. Estelle Cortella-Blanc, "I don't use opioids for headaches. They are known to cause rebound headaches and medication overuse headaches with even low frequency use, and it's a mess for us to undo down the road." Okay, so back to our case. You decide to offer Anna an SPG block given that she still has some ongoing pain despite her treatment so far. Within 10 minutes, her pain is much improved and she feels ready to go home. So what now? In part 3, arguably the most important part of our talk today, we're going to explore why it's so important that even as emergency physicians, we adopt the practice of prescribing abortive and preventative therapies to our migraine patients, and we'll go over how to do this. Let's start with abortives. As you know, sometimes lifestyle measures, such as maintaining a regular sleep-wake cycle, eating right, exercising regularly, are just not enough. And by the time a patient has made their way into RED, this is usually the case. Sorry, I think someone has their mic on.
Abortive?
I have my mic on.
So we need to be able to offer them something else aimed at stopping the migraine in its tracks and preventing its progression for whenever their next attack occurs. And this is especially important considering that 2 out of every 3 migraine patients have a recurrence of their headache pain within just 48 hours of discharge from the ED. This is a major problem. We need to recognize migraines as a spectrum of disease and chronic migraines as a complication of poorly controlled episodic migraines, making it all the more important to properly treat acute migraine attacks. This is why counseling on the use of abortives needs to be routine for us in the ED. It'll reduce disability and reduce bounce backs. The top 3 recommended abortives are acetaminophen, NSAIDs such as ibuprofen or naproxen, and triptans. The most commonly prescribed triptans are sumatriptan, zolmitriptan, and rizatriptan, with the first having the benefit of coming in a nasal spray formulation, and the last 2 available in rapidly dissolving wafer formulations. Patients can use one from any of the 3 categories of abortives, or they can all be used in combination as long as their use is kept to less than 10 days per month, so as to prevent medication overuse headaches. All of these should be taken at the first sign of a headache and should be taken with plenty of water. But when we look at the TOH survey results, the majority of us are not prescribing triptans. Perhaps this is due to concerns regarding triptan contraindications or cost. I'm not sure. However, I would argue that the more options the patient has to abort their migraine, the better. The goal should be to crush the headache and to crush it early. And so I would urge you to consider them in any and all patients with migraines, assuming they don't have any contraindications, such as coronary artery disease, peripheral vascular disease, or uncontrolled hypertension, in addition to your regular Tylenol and NSAID recommendations. Still, this only covers half of the appropriate treatment of migraines. So let's move on to the other half with the preventative therapy section of our talk. As you're probably aware, these are medications that are prescribed for longer-term daily use with the goal of reducing headache frequency, duration, and severity in certain patients with migraines. Now, if you're thinking that this isn't really something we need to consider as ED docs, first, consider this. A retrospective US study done by Silberstein in 2003 looked at how long-term resource utilization was affected by the use of migraine preventative medication when added onto a regimen that already included acute therapy. They found that with the use of migraine preventatives, there was a staggering drop in ED visit rates by almost 82%. Outpatient clinic visits for migraines were cut in half. And the number of CT scans that were ordered was decreased by 75%. These dramatic outcomes are also supported by a large systematic review and meta-analysis done by Chamlian and colleagues in 2013, which included 66 RCTs evaluating the benefit of prophylactic meds in reducing monthly migraine frequency by at least 50%. They found an overall odds ratio of 2.5 favoring prophylactic medications, but even more impressively, the number needed to treat ranged between 3 to 6 patients. This is on par with the NNT for embolectomy and large vessel occlusion in stroke. I know, OMG, right? These numbers are actually mind-blowing. However, when we look at our survey results, it's clear that the majority of us are not prescribing prophylactics, and we're not alone. A study by Lipton in 2007 found that 40% of patients with migraines met criteria for prophylaxis. However, only up to 12% actually received it. So there's clearly a discrepancy here between what we could be doing and what we're actually doing for our migraine patients. So I'd like to take this opportunity now to open up the mics for a minute or two to hear from you guys why you think we aren't prescribing these from the ED, and maybe we can break down some of these barriers. And I can't see your chat function, guys, so please don't be shy to unmute your mics and just say a few words.
I mean, I think this is Mike Wong. I think it's a lack of familiarity and a belief that any long-term medication should be prescribed and followed by a family doctor.
Right.
But I would agree that we have a role in initiating primary care.
Yeah, excellent. I was thinking about those things too. Anybody else?
I was.
Dr. Greenberg had written.
Oh,
sorry, you go first.
Hey, Megan, it's Doran. I was just going to kind of echo what Mike Wong was saying, that I think a lot of it relates to an unfamiliarity with the medication compared to something we use very routinely like metoclopramide.
Right, totally.
Dr. Greenberg had written, patients will want us to re-prescribe the medications when they run out.
So patients will want us to re-prescribe?
The medications when they run out.
When the medications when they run out. Yeah, totally. So these are all kind of the same thoughts that I had when thinking about this. I was thinking that, people would probably say that we don't know how to prescribe them. We're worried about titration and side effects, concerns about possible follow-up, and maybe thinking that this isn't within our scope of practice and maybe should be left up to neurologists or to family physicians. So, all good thoughts, guys. Thank you so much for your input. Let's see if we can address some of these next. So my goal for this next section is to shed some light on what is actually a huge gap in our care of migraine patients. My goal is to help you see that our current practices are only scratching the surface of what we could be doing for them. I hope to show you that with a few simple steps, we can close this gap, drastically improve patient care, see dramatic reductions in ED visits, and alleviate the significant economic and societal implications of this condition. So as we mentioned, some of you may be thinking that this isn't really in the realm of what you feel an ED doc should be doing, but I would argue that it is. Whenever we treat any chronic medical condition, we should strive not only to treat the acute presentation, but also do what we can to prevent it from coming back. So just as we wouldn't treat an asthma exacerbation in the ED without sending the patient home with puffers, or a CHF exacerbation without outpatient diuresis, we arguably shouldn't be sending migraine sufferers home without a similar outpatient management strategy. As Emerge Docs, we're constantly expanding what we consider to be within our scope of practice. And I think many would agree that an SPG block used to be outside of our wheelhouse, or that the prescription of gabapentin for alcohol withdrawal was too much. But look at us now. Many of us are already doing these regularly for our patients. So let's add something else to our toolkits. I'll show you how with 3 simple steps. Step 1, refine your migraine history with 3 key questions to identify candidates for prophylaxis. Step 2, select medications and explore options for comorbidity co-treatment. And step 3, educate your patient on expectations and medication overuse. So let's start with step 1, refining your migraine history. If you'll recall, at the start of the talk, I mentioned that migraines come in different flavors, and that differentiating between them with a proper migraine history is vital if we want to do more than just temporize the issue. To put it simply, I'll break it up into the 3 migraine syndromes you're most likely to see: episodic, chronic, and medication overuse. Let's look at these a little more closely. Patients suffering from episodic migraines are those with a history of migraines who spend less than half the days of a month with a headache. Those suffering from chronic migraines will spend at least half the days in a month with a headache, with just over half of those headaches classified as a migraine. And similarly, with medication overuse, the patient will spend more than half the days of the month with a headache, with analgesic medications taken on 10 to 15 days of the month. With 3 key questions, you can quickly differentiate between these 3 types. Number 1, on how many days per month do you have a migraine? Number 2, how many headache-free days do you have per month? And lastly, number 3, on how many days per month do you take medication for headache pain? With these questions, we can quickly identify many of those who would benefit from prophylactic therapy, as outlined in the guidelines shown here, by teasing apart the different migraine syndromes. The guidelines universally recommend that we offer migraine preventatives to the following populations, which I've broadly categorized into 3 groups: those with frequent headaches, those with issues with acute treatment, and those with severe symptoms. Specifically, anyone experiencing 4 or more significant headaches or migraine attacks per month, anyone having 8 or more headache days per month, even if their acute migraines are medications are effective, anyone with medication overuse headaches, or those who have contraindications to acute migraine treatment, anyone with severe or disabling symptoms despite having infrequent attacks, such as those with migraine with brainstem aura or hemiplegic migraines, or those describing a significant impact on their quality of life. Okay, on to step 2, choosing the right medication for your patient. There are many different medications available that have been studied as migraine preventatives with varying levels of effectiveness and different side effect profiles. I've selected the top 3 preventatives with the highest quality data and strongest recommendations from the CHS and created a cheat sheet here for you that I've included on the handout that I sent out so that you can use it on shift. These are also the first-line therapy options used by our neurology colleagues as well. These 3 have very similar levels of efficacy, so when selecting which one is right for your patient, I suggest considering if there's anything else you can co-treat at the same time, while of course taking into account the side effects and contraindications. The first on our list is metoprolol, and the starting dose is 50 milligrams BID. It should be noted that for all these medications, the doses listed here are the starting doses that will need to be further titrated to effect, which can be done in follow-up with neurology or with the patient's family physician. Metoprolol also has the benefit of co-treating hypertension, but should be used in caution when those with asthma or COPD, hypotension, or bradycardia. Similarly, propranolol is another great option that comes with a strong recommendation. The second option shown here is amitriptyline, with a starting dose of 10 milligrams QHS. It's a good option for those with insomnia, depression, or neuropathic pain, but patients should be cautioned about possible weight gain and anticholinergic effects, and it should be avoided in people with long QT or a history of seizures. Some experts have also recommended nortriptyline as another option with a possibly better side effect profile. However, currently the research has focused more on amitriptyline. The third option here is topiramate, which is started at 25 milligrams QHS. It's a great option for those with essential tremor or with trigeminal autonomic cephalalgias, such as cluster headaches. The most common side effects reported include weight loss, paresthesias, and mood and memory changes. It's best to avoid using this in a patient with a history of kidney stones or glaucoma, as these can be precipitated, and it should be used in caution in any women of childbearing age, as it's a known teratogen associated with cleft palate. Valproic acid and gabapentin are two other options available for you to consider. However, the evidence is not as strong to support their use, so I won't go into detail about them today. Additionally, despite not having much evidence to support their use, the nutraceuticals listed here come highly recommended as low-risk, well-tolerated options for prophylaxis. I've also included these on the handout I sent out for your future reference. Okay, now moving on to step 3, educating your patient. It'll be really important to manage your patient's expectations when starting their new medication. First, they should know that the goal with prophylaxis is to reduce the migraine burden by reducing migraine frequency and number of headache days by at least 50%, as opposed to completely eliminating them. They should know that you're getting them started at a low dose until they can be seen by their family physician or neurologist, who will be able to further titrate their dose to effect. It's also reasonable to give them self-titration instructions to get them off to a good start, as it may be a while before they're able to see neurology. I've included the titration doses on the handout that I sent out. You can tell them that it usually takes about 2 months of being at their target dose before they see the full benefit and to not give up early. And lastly, you should recommend that they record their symptoms in a headache diary, as this will help neurology when they see them in follow-up. Lastly, I'd just like to say a few words on the importance of identifying medication overuse headaches. While we know that these patients will likely benefit from prophylactic therapy, they'll still require education about limiting analgesic use to less than 10 days per month. Failure to do so has been shown to be associated with an increased risk of preventative medication failure and has been identified as one of the most important risk factors associated with migraine progression from episodic into chronic. Our neurology colleagues will help us with this discussion, but we can easily start it in our ED. So your take-home messages from this section are twofold. 1, remember that recurrence rates are high after discharge and that all migraineurs should be prescribed abortives. 2, we have the potential to make huge strides in the care of migraine patients with just 3 simple steps. Asking those 3 key questions on history to identify candidates for prophylaxis, prescribing preventative treatment when appropriate, and educating patients on preventative expectations and avoiding medication overuse. So before you send Anna back to her castle, you dig deeper and find out she's suffering from chronic migraines and medication overuse, and she meets criteria for prophylaxis. You discuss the importance of proper lifestyle measures, including ensuring proper sleep hygiene, avoiding alcohol, and limiting caffeine intake to 1 to 2 cups of coffee per day. You prescribe her zolmitriptan as an abortive therapy. You start her on amitriptyline for migraine prophylaxis, which will also help with her insomnia. And you give her self-titration instructions. You give her a 1 month supply, which should be enough to last her until she sees her family doctor in follow-up, and you place an outpatient referral to neurology for further management. She leaves feeling hopeful at the prospect of relief from this disabling condition. This brings us to the last part of our talk today, which will focus on future directions in migraine management. We'll discuss the upcoming CGRP antagonists and dietins for acute migraine management. Let's start with the CGRP receptor antagonists. Calcitonin gene-related peptides, CGRPs, are neurotransmitters that are released during a migraine attack and facilitate pain transmission. Just recently, a new class of drugs that antagonizes the CGRP receptors have been studied for the acute treatment of migraine headaches. Their proposed benefit is that they do not cause vasoconstriction, so they may be used in patients with contraindications to triptans. They've sparked interest for acute therapy as other drugs targeting CGRP receptors, specifically CGRP monoclonal antibodies, are now being used in Canada for migraine preventative therapy. The Achieve trials are two recently published studies evaluating the new CGRP receptor antagonists. Specifically, they were phase 3 multi-center double-blinded studies evaluating the efficacy, safety, and tolerability of ubrogepant compared to placebo for the acute treatment of a single migraine attack. Given that these trials were so similar, we'll critically appraise them concurrently. The Achieve 1 trial compared ubrogepant doses of 50 and 100 milligrams to placebo, while the Achieve 2 trial compared doses of 25 and 50 milligrams to placebo. The primary efficacy outcomes were pain freedom and freedom from most bothersome migraine-associated symptom, such as nausea, photophobia, or phonophobia, both at 2 hours after the initial dose. In the Achieve 1 trial, they found that the percentage of participants who had freedom from pain and absence of the most bothersome symptom was significantly higher among patients who received either dose of ubrogepant than among those who received placebo. Similarly, in the Achieve 2 trial, they also found patients in either ubrogepant groups to have significantly higher rates of pain freedom than in the placebo group. However, only the 50 milligram dose of ubrogepant was associated with a significant difference in the absence of the most bothersome symptom, suggesting a dose-response effect between the 25 and 50 milligram doses when referring to freedom from most bothersome migraine symptom. The most commonly reported side effects were nausea, somnolence, and dry mouth. In conclusion, these trials found ubrogepant to be more effective than placebo in achieving freedom from migraine pain and relief from most bothersome symptom at 2 hours after administration. Overall, these findings are promising for the future of acute migraine management. However, some limitations include that there were no active comparators in either of these studies, so we don't know how they fare against our currently available medications. Secondly, the results were based on a single migraine attack, so this limits our ability to assess consistency across multiple attacks, as well as to assess safety with repeated use. Lastly, I'd like to say a few words on another new class of medications called dietins. They are serotonin 1F receptor agonists that, similarly to the CGRP receptor antagonists, do not exert a vasoconstrictive effect when activated, making them a nice alternative to triptans. For the sake of time, I won't go into these trials in detail, but essentially, there were 3 phase 3 clinical trials by the super cool names of Samurai, Spartan, and Gladiator trials, which compared the effectiveness of lasmiditan to placebo and examined adverse effects. Their results suggest that lasmiditan is more effective than placebo at relieving acute headache pain at 2 hours and may be a new, safe, and effective option for acute migraine treatment, especially for patients refractory to or unable to tolerate triptans. And in the past year, both ubrogepant and lasmiditan were FDA approved in the States, so keep your eyes out. These will hopefully be coming soon to an ED near you. The take-home points from this last part of our talk today is that CGRP receptor antagonists and dietins will likely be future available medications that can be used in the abortive treatment of migraines. Research is still in the early stages, but hopefully these meds will offer another option for acute migraine management. Now, before we wrap up, let's just quickly review the big take-home points from today. A good history is vital to proper migraine management. VPA and SPG blocks are good options to consider when treating acute migraines in the ED, especially in those who may be refractory to our common ED cocktail. The evidence does not currently support the use of ketamine in the ED for acute migraines. We should stay far away from opioids as these are bad news when it comes to migraines. The prescription of abortives should be considered in all patients who present with migraines. I strongly urge you to consider starting migraine prophylaxis when appropriate, as we can make huge changes for patients and the system as a whole. And there are new and exciting advances in migraine management around the corner, so keep a lookout for these. And lastly, I've created an algorithm which covers my approach to the migraine patient and encompasses essentially all the important points we've discussed today, which I've included in the email I sent out for your reference, and I would be happy to answer any questions that you have about it. Thank you all so much for your attention today. I'd like to thank my supervisor, Dr. Miguel Cortel LeBlanc, for his guidance and wisdom in preparing me for my first ever